Hi, good afternoon, everyone, and welcome to the final session of the CCBHC Child and Family Focused Learning Community, brought to you in partnership between the National Council for Mental Wellbeing, NASHBID, and the Institute for Innovation and Implementation. And of course, the CCBHC Expansion Grantee National Training and Technical Assistance Center. We've been learning together now since February. So this brings us to our final event, which we've intentionally focused around workforce, right? So we can talk about all of the clinical and operational pieces that drive care for children, youth, and families. We've talked about EDPs and screening and assessments and care coordination and data collection, but we really can't do any of that work without a skilled workforce. And as we are all too acutely aware right now, we're in the midst of a workforce crisis. So the hope for today's session is that you will walk away from this session with ideas and innovations that you may be able to employ in your state and clinic CCBHC work. So as always, a reminder that we have our presentation today and we save questions for the end. So you can share your questions via chat at any time during the session, and we'll get to as many as possible at the end of the session. We go to the next slide, please. Just want to give a brief disclaimer that although this publication was made possible through SAMHSA sponsorship of the CCBHC Expansion Grantee National Training and Technical Assistance Center, the contents are solely the responsibility of the authors and don't necessarily represent the official views, opinions, or policies of SAMHSA or HHS. Next slide. So before I jump into our presenters, I just want to set a little bit of context around what we'll be focusing on today. Within the CCBHC criteria, there are staffing requirements that needs to be made, which can be found in the full criteria. Elements specific to children, youth, and families include staffing individuals with expertise in addressing trauma and promoting recovery of children and adolescents with SED, such as child and adolescent psychiatrists and staff trained to provide family support. But during this session, we're not going to really talk about those criteria. What we're really going to do, which is what we typically do, is start with a national landscape thinking about staffing in this case, and then showcasing a state case study. So nationally, we'll talk about workforce programs states can employ to build and expand a skilled workforce for children, youth, and families. And then we're going to focus on Oklahoma as our case study today. So we'll talk about Oklahoma's workforce investments and innovative programming, including use of data to identify need and target solutions. And then we'll have Grand Mental Health, who has been a demonstration and grantee CCBHC, talk about their workforce redesign, recruitment, and retention strategies. So I'm so pleased to be joined by Michelle Zabel, who is the Assistant Director and Dean of the Institute for Innovation and Implementation, Sheamekah Williams, who's the Director of Children, Youth, and Family Services at the Oklahoma Department of Mental Health and Substance Abuse Services, Josh Cantwell, who's the Chief Operating Officer of Grand Mental Health Center, and Larry Smith, who is the CEO of Grand Mental Health. So with that, I'll turn it over to Michelle to take it away.
Thanks, Sam. I'm really happy to be here. I have to say the Institute works in 3/4 of the country in your states. And as a group of people who've come together to help improve outcomes for children, youth, young adults, and families, we focus a lot on workforce development. So when I was asked to be part of this particular panel, not only was I excited because I like all these people from Oklahoma and they have a great story to tell, but also this is near and dear to my heart. And all of us know, as Sam said, none of this work can happen without a skilled and qualified workforce. So if we could go to the next slide. She talked a little bit of the model of what we're going to talk about today. We hope you walk away understanding a little bit more of team-based treatment models, utilization of peers, innovative approaches to recruitment and retention, and then leveraging technology to maximize a workforce. So if we could go to the next slide. Okay, so I know I'm preaching to the choir, but I am going to set a little context here. So Over the past decade, the prevalence and needs for children's mental health has skyrocketed. Certainly, COVID did that to us even more. And therefore, our need for even a more highly skilled workforce has been rising. So our incidence of depression, suicide, all of it has just been through the roof for over the last 10 years, with the last 2 to 3 years really being even higher than I think probably any of us would have expected. Before the last decade. And you also all know, because you're leaders in this work, that we've actually declared a children's mental health crisis in this country. And that does lead us to the opportunity for even further innovation, some of which Oklahoma is going to talk about because they've used resources from the federal level and so on to really enhance the work that they're doing. One piece of context that I want to put out there is that the American Academy of Child and Adolescent Psychiatry is saying that right now, nearly 1 in every 5 children is experiencing a mental health issue, but only 20% of those children are receiving care. So our mental health workforce crisis is in the context of we're still not reaching everyone that we need to reach, right? So our knowing that over 2.5 million in the US have major depression, that even amongst those youth with severe depression, only 27% are receiving it. And then I think one of the things we really should be paying attention to is in those states with the least access, they're really only about 12% of the youth are receiving any type of consistent care. So we're not only not finding all the youth who need our support and having a workforce crisis, but we're also in our most under-resourced states, not even reaching them to the level that a resource state is. And then you add on to it this issue of private insurance who doesn't have any health care for mental health at all. And you kind of add to the number that we're all trying to reach and support across the country. CCBHCs being an excellent leader, because all of you that have decided to become CCBHCs are visionaries. So understanding that context, I think, is just really important about what the N is. What's the number that we're trying to get to in terms of our workforce? Can we go to the next slide, please? So Mental Health America did an updated study just in 2022. And this, I would encourage you all to just take a quick look at it because it gives you a sense of the real disparity across the country in terms of workforce availability. We've already said a couple times now that the work we do is only as good as the workforce that we're able to recruit and retain. And we know there's no magic solution, right? So, but today is about really those innovations that are happening. And the report was interesting when I read it because we're all under the impression that like people aren't coming into the field, but in actuality, what Mental Health America was saying is that we do have a lot of the same numbers of people coming into the field. It's that issue we talked about on the previous slide. It's that the growth of need is so high that we're not keeping pace. So not only, so if you've got a state or a community or your own provider world where you're seeing the same number of students coming through, or you're doing some of the same things, it isn't as much about, like I said, this issue of like, are enough people coming into the field? It's that we have such a growth of need that more people need to come into the field. For clarification, when Mental Health America talks about who's in our field, I think this is important too, especially when we get to recommendations, that we're talking about traditional folks, psychiatrists, psychologists, licensed social workers, mental health counselors, all the things. In this chart, in this map, they're not talking about peer support counselors or paraprofessionals because the inconsistency across the states didn't allow them to actually quantify that. And you'll see in recommendations and things that Oklahoma is doing as well, that it is within that peer support and paraprofessional world where we have to find some of our growth of workforce, right? One other way of thinking about this in terms of our workforce shortage is that when you look at the need for children's behavioral health against the workforce numbers, the the discrepancy between what our workforce should be is greater than pediatric and dental care combined. So like the lack of people in pediatric care and dental care versus the lack of workforce professionals in mental health were higher. So the type of recruitment and work that we have to do needs to be much more innovative, much more aggressive, and much more on point to bring people in and keep them. Let's go to the next slide. So again, today is about innovation. And so many of your states and you as leaders in your own organizations have plenty of examples. And I would really encourage you to use the chat to drop those in. So we're going to quickly soon focus on Oklahoma. But if you've got things that you're doing, state and local, please chop them into the chat. The National Governors Association really pointed out a few points and areas that we can all combine on those. So that let me do some just real quick opportunities for innovation. And one of the things that I thought was really important was to never ignore the issue of salary, right? So at a base level, as executives like Josh and Larry will talk about, unless there are rates that providers can pay people better, we will always be in a situation where our recruitment is behind other fields, where people that wanted to come into our field might choose other fields. So this issue of rate setting and loan repayment is key for our industry to bring in the right amount of people. In the first bullet, the NGA puts out, National Governors Association puts out, they really do talk about the training and hiring. And so many of your states have centers of excellence where states themselves are investing in paying for training for people. And I would encourage you, and Denise is going to be dropping things into the chat, but I would encourage all states to really consider that as a key way of taking cost off providers and cost off workforce, to be ensuring that the skill enhancement is paid for at a different place, that that actually is something that the state takes some responsibility for and that providers can benefit from. Additionally, you'll find in a lot of states that, I'm going to pick on schools of social work, that sometimes schools of social work, because I'm in one, don't actually have all the coursework that a provider needs them to have when staff come out. And so there have been initiatives across the country where states or national entities have worked with schools to actually add coursework that is in line with what providers need. So it's not just on field placement and it's not just on supervision, but it's actually coursework that combines and brings people out with improved evidence-based skills and work. And so I know that in our later example, Larry and Josh are going to have some examples of what they do in their own organizations, but we've also seen those partnerships happen across schools. And it's important for your public universities in particular to feel some responsibility for the workforce that they're graduating so that providers can actually hire people that will help benefit kids and families. The second example is aligning curriculum between two-year colleges and four-year college and university. So right now in the US, we have 31 states who have created policies that allow for people to go from a community college into an undergraduate degree, and that coursework completely transferred, that person doesn't have to actually go back and take additional courses, that it's just completely transferable. People are doing that through regulation, they're doing it through legislation, and they're doing it through policy. But it is absolutely an important mechanism for us to keep lowering the cost of education to bring people into our field. And those states that are doing it are finding success, that people are using that. In Maryland, Denise just dropped it in the chat. Since 2016, we've had that model. It's been regulated. In Massachusetts, interestingly, it was done at the Massachusetts community college and university system level, and it was just a bunch of letters, MOUs, between all of the college presidents. It didn't even take the government to do it. It was done at that, college level. But that is one major mechanism that we can keep lowering costs of higher education for people coming into our field. Again, sticking with the money issue, figuring out ways to continue to offer incentives is really important. And I'd encourage you to look at Michigan's loan repayment program. They have the highest in the country that we're aware of at this moment in time. They have loan assistance amounts up to $300,000 over 10 years. That's a significant amount of incentive to help people come into our work. Alaska also created an incentive program to increase and spread the practitioner base. And Colorado has an actual apprenticeship program that they've recently launched to help grow the workforce in behavioral health and create career pathways from high school all the way through graduate school degrees. So those are a few states I'd love you to just stop and look at and see if those are mechanisms that can be actually used in your state as well. And then finally, sticking with this apprenticeship approach, Frontier Area Rural Mental Health Camp and Ambassador Program is a model that is using high school and field placement approaches to pull people into our field at the high school level. And then there's such a thing called the Virtual Mentor Network, which is also a way to bring high school students in and have them be connected and mentored by people in our field. So Alabama has a actual registered apprenticeship program, and the list goes on. And hopefully, I'm sorry, I haven't been watching the chat, but I'm hoping you're dropping things in as well. The level of creativity that we have to come up with to actually combat this issue of people wanting to work in our space is really important for all of us to connect to. And Sheamekah, I'm going to hand it to you so that you can talk about all that you've done in Oklahoma.
Thank you, Michelle. As Michelle mentioned, there are several different ways to really leverage your workforce and create opportunities for that. One of the things that I really want to talk about is as a state system, we look at every opportunity through Medicaid to build services around Medicaid capacity, not just for the clinically licensed practitioner, but also looking at levels like family support, behavioral health aides, employment specialists, and those types of individuals that can be reimbursable through Medicaid. Also, I think communities of practice. I think that it's also important to really strategize around how to work with people in your community in order to support families with some of the needs that they have, and really strategizing in ways of creatively looking at specific roles, such as 4E roles with child welfare that can be partnered and funding can be provided. In addition to that, our state system has an infrastructure where we try to leverage and take a lot of the training capacity off of providers. So we have a statewide training capacity where we have specialty experts that provide training, and most of our trainings are at no charge. In addition to that, we do on-the-job coaching. It's not about just putting someone in the field and sending them through a training, but to have someone that can provide the additional coaching support in order to build their skills level is really important. And then also the onboarding process. We really try our best to give our providers a platform for job descriptions for non-licensed clinical positions, job descriptions that really allow people that may be maybe they have a bachelor's degree, or maybe they don't have a bachelor's degree like a family support provider, but really that onboarding process and creating training at our Center of Excellence in a way that really helps to build the skill level for those individuals. And then also, really centralizing local and accountability. You know, we have a data system at the state level where we can actually leverage numbers. We can see the capacity in the state of Oklahoma where individual kids and families may have high numbers of mental health need in specific areas. And so we can target that and share with our provider level so it actually helps them to see what areas they need to build capacity around. Next slide, please. I think it's also important to know that Oklahoma is definitely a rural state. Our foundation is our Systems of Care Foundation, where we follow the values and principles for all children's services within our state. It's also important for us as we continue to to really look at what families need. And sometimes what families need may not be under a Medicaid capacity, but how do we build state services out where these capacities can be provided, like housing services, housing specialists, to a point where if you have a housing specialist at a provider agency, those services are reimbursable. In addition to that, we have behavioral health aides who work hand in hand. These are non-degree positions, hand in hand, one-on-one with young people, and helping them to build their skills level around their mental health, helping them to maintain environments where they need support, such as school environments or even home, and sometimes in local places in the different communities. And so again, really working at the state level to look at those opportunities where you can build services around the needs for families in a way where we're not always dependent upon a higher degree level or a licensed clinician in order to support families with needs that can be supported by individuals that maybe have a different skill set. I think it's also important, as the Grand Lake will share later on, us being a rural state, large in proximity, the utilization of technology. It is amazing what technology can do, how you can do face-to-face interactions and face-to-face opportunities with young people in rural communities who may have to drive 45 minutes, 30 minutes, or an hour in order to seek services. In addition to that, when you're looking at a capacity where you're serving really kids that are higher needs, how can you do more frequent opportunities for treatment with those young people in a way where maybe it's multiple times a week? And so technology has definitely been a big leverage of that. I think in addition to that, the opportunities that states have to share and to train and to support communities around children's mental health are huge. People in our communities really want to understand more. And so any opportunity, mental health first aid, My Mind Matters, any of those types of trainings could really be helpful for community people, because again, as we all went through COVID, we know the rise from COVID was significantly huge and created a challenge, but our communities were not as prepared. We do also other trainings for healthcare professionals and law enforcement officers, where we train them, again, how to interface. And so really leveraging not just the community, but really leveraging opportunities where you can build your workforce capacity. Next slide, please. I think really strategizing as a state and really strategizing in multiple levels. I think it's a 3-level capacity. At the state level, really looking at not just what the need, but what does your data show is the population of need, or the focus for you as a state? And how do you build training? How do you build services? How do you build a design around that capacity that leverages and allows the providers to I guess the word is benefit from that, to be able to be reimbursed for services that they're paying, to be able to hire people at higher levels of services, to be able to utilize pay incentives. How do you leverage some of the national opportunities that provide reimbursement for schooling? In addition to that, partnering with university. Right now we have there's a shortage of psychiatrists around the nation. Well, how do you leverage with School of Psychiatry or School of Social Work or other schools to really build that capacity in your state when those students are coming out? In addition to that, I think that it's important at the community level, as I mentioned, training communities and sharing with communities about their support and how they can work, how they can support children and families who struggle with mental health issues. I mean, really looking at your schools. How do you build programming around your school systems that really help to reduce, the number of kids that are going into crisis? How do you build a program where you can actually embed staff that may not be at the highest level of staffing needs, such as a clinician or a therapist? But how do you build those programs around your communities and your school systems to support these youth? And then also at the individual level, I think it's really important for us to listen to the families in order to be able to provide them with their needs. What we learned through COVID is our capacity and our ability to really work with parents was really critical, because parents then were able in return to work with their children. And so really looking at ways, our family support providers are amazing and have really built a great reputation in the state of Oklahoma, where they work with parents, helping parents to develop the skills so that they can better care for their kids. And so really strategizing from the top, what does your data say? How do you use that data to develop services, supports for your community, as well as to leverage individual level services? Next slide, please. I think, again, Michelle pretty much said all of this, really looking at ways to enhance the fidelity around the work by partnerships with universities and colleges and other things, but then also really allowing your workforce to develop really allows you to be able to maintain the fidelity of your services, be able to provide the evidence-based practices. So really you think about strategies like coaching, mentoring, when you think about strategies such as, the numbers. I mean, if you have kids with high numbers in your system that may be coming from a particular system, and you have staff that work really well with that population, whether we're talking about the early infant mental health population, whether we're talking about juveniles, whether we're talking about kids who are homeless, how do you begin to adapt those staffs in areas where they can be successful and feel fulfilled in the roles that they're in the roles that they're doing? Not everybody is successful with juveniles. So how do you leverage your workforce in a way where people are fulfilled with their role and they're doing a great job? And again, more likely to continue to maintain that. And so really strategizing and planning is really important. Next slide, please. Again, developing a community of practice. This is really what this is all about. I mean, we can, at the state level, we can develop these things, and we can develop services, supports, we can develop roles and positions that are critical. But I think it's really important to not just to foster collaboration and really work with other systems and colleagues in order to strategize around that. I think it's also important to really look at real world issues. Majority of our families, when they come in, they don't often know what they need. They don't often know. Very seldom will a family come in and say, my kid needs, therapy. Most of the time it's my kid needs help. And how do we help them? And so really leveraging the support. There's only so many hours in a week, in a month, that a therapist can actually provide individual therapy or family therapy. In most states, there's a limit to that. And so really, how do we look at our bachelor's level staff, our case managers, our care coordinators? How do we look at our family support providers, our BHAs, our peer support, our housing specialists to create that capacity? I think one person said it's like building a hamburger. There are certain things on a hamburger that everybody eats. There are certain things that they need, but there's certain things that certain families need at any given time in any given place. And sometimes it's really those basic things that they need, that one-on-one from a family support that says, I've been there and done that. Let me help you. Let me show you the way. And so really building a capacity for staff and leveraging that capacity. I think a lot of times we're in crisis, as Michelle mentioned earlier. We are looking for those licensed clinicians around the nation to fill that capacity. But really think about what is the capacity that you're trying to fill, and how do you build that, and really build a practice in a way for those people to be successful. Whether we're talking about, we have state level infinity calls where we get all of our care coordinators on a call bi-monthly in order to talk about what's happening around the state and to really enhance their practice level. Next slide, please. And then also, I mentioned this earlier, I kind of pre-mentioned this, data-informed decision-making. Utilizing your data in order to drive your workforce is really important. And what I mean by that is, again, looking at the hot spots in your state, in your agency, in your areas, in order to determine what that capacity needs to look like. It will help you from overstaffing, understaffing, whatever that may be. And then building an infrastructure around the currency of now, projecting ahead, really looking out within, the next year. What do our numbers look like this year? And where do we need to position our staff in order to make that happen? And then again, always surrounding yourself with people and experts, multiple different experts from the community level to the state level, provide in order to help you to do that. And then never forget about the use of technology. I think COVID was a huge thing where a lot of states were going to technology infrastructure and really doing face-to-faces and times utilizing those technology instruments. Well, how do we continue that in today's platform? The medical field continues it. They use it. You can have doctor's visits continuously on face-to-face through your phone. How do we continue to leverage that? And then also really leveraging opportunities for funding. As I mentioned, different funding opportunities such as, SAMHSA grants are huge and great to really look at these things, but then also your state waivers, Medicaid, really looking at Medicaid infrastructure to build clinically licensed positions. And then also always go back and review your data see what it tells you in order to help you to continue to build your workforce and support your workforce. Next slide, please. Again, the goal of forecasting is not to predict the future, but to tell you what you need to know to take meaningful actions in the present. I know people oftentimes wonder, data and workforce, it is connected and it is extremely important. And so again, just a reminder, the things that you have can help you to forecast and can help you to make decisions around your workforce as you continue. And then building the capacity to support them at different levels could be huge, and your outcomes will really be successful. All right, next slide. All right. Same thing. I mentioned forecasting, I mentioned all of this. So I'm going to go to the very last slide. So these are capacity sites, and this is some examples of our data where we're able to hotspot and look at county level data in order to determine what type of crisis team, the number of teams that we need in different areas, but then also to tell us a projection of really what's happening, what kind of crisis calls that are coming in for the kids that we're going out on crisis calls. So this is examples of data and what our data tells us in order for us to forecast and project staffing ratios, in order to project community trainings, in order to project embedding staff into schools to provide additional support. And so these are some data examples. Next slide. Again, our projections tell us days, times, weeks, months, pretty much everything we need to know it, in a sense. And if we can project the date and the time for a particular community, a particular provider area, then we can provide that information to the provider so they can strategize around whether it's training in the community, whether it's staffing up, as I mentioned earlier. Next slide. All right. So really excited to share from a state perspective how we support our providers, but I'm going to turn it over to Josh and Larry from Grand Lake, who is one of our mental health treatment providers, CCBACs in the state of Oklahoma. Thank you, guys.
Sheamekah. Yeah, thank you, Sheamekah. Great job. What a lot of the stuff Sheamekah talked about, we've taken and we put it into practice with the leadership of the Department of Mental Health, with their guidance and their assistance and all the data that they have. We've developed a system. Grand Lake Mental Health sits in 12 counties. The map in front of you is the 12 counties pulled forward, plus Tulsa. We have an addiction center there. Just to explain kind of where we're at, we're in rural Oklahoma. The dots are where we have clinics. The red dots is where we have crisis services, and the blue dot, which is in Bartlesville, is where we have a brief stay therapeutic home, which we're going to talk a little bit about and not spend a lot of time on it because we have so much information to give you, and it's pretty exciting. Josh, you got anything to add to the map here?
I do not. We can go on to the next slide.
Okay, next slide.
Well, we're going to take the opportunity today. We're going to talk about a few of the innovative things that we're doing surrounding workforce development, specifically with the youth and the families that we're serving. It's interesting. I thought that Michelle and Sheamekah did a great job characterizing this unique conundrum that we find ourselves in. So we are actively working to increase access to the people we serve. We know that there's miles to go before we're providing services to all of the people who need it at the same time that we're facing this workforce crisis. So for us, that means that we have to learn how to do more with less. And that's what you're going to hear as themes through these things that we're talking about. one of the ways that we've done this is truly try to get rid of any inefficiencies in the services that we're providing. So for years, we've been in a situation where we have provided maybe loosely coordinated care between our different providers. And not that we didn't try, but we would have therapists that would be responsible for providing psychotherapy for a certain number of hours in a week. And then we would also have case managers and care coordinators doing the same thing. And then we had people with lived experience working also, but no one was taking this deep dive into how those parts were interrelated with what we're trying to accomplish now. What we've done is we've created this true, very intuitive team-based approach where the client becomes the nucleus of everything that we do. And we just focus all of our efforts directly at that. So what that means on this core team, you've got an integrated team manager, which we're going to dig into in a second because it's a very important part of how we're leveraging every bit of our workforce. But that person is a licensed behavioral health provider, and then we have a care coordinator, and then someone with lived experience. So it's a family support provider who's on this team also. Well, that team is guided by the integrated team manager with the sole purpose in mind to serve a population of 40 individuals, but manage the overall health care, including mental health and addiction care of those individuals that are on the caseload. That's the only goal. We're starting at the end, and you're going to hear this as a theme also. Our goal is to improve the health outcomes for that 40-person panel that they're serving. And so the visibility is on all of those positions, and it's done in a way to where we tie in the rest of our team, which has never been done at this level before. So every team, if you have a map that's lining out from the client all the way up, the client knows who is responsible for therapy, care coordination, support services. We know the RN that's involved in the team. We know the other supportive services like occupational therapist, employment specialist, housing specialist, the advanced practice providers, and also the psychiatrist that's working with those individuals. So that visibility and that laser focus on a smaller caseload of individuals is proving to have a lot of efficiencies that we were not seeing with the other models for providing care. Larry, would you like to comment on this slide?
Yeah, we're going to talk a little bit more about the detail of how we recruited these people and how we train them, how we educate them, how we train them to do the jobs that they do, and how important it is that we're able to recruit and retain staff. And so that's part of this presentation, because when you only have 40 clients, I say that because we used to have caseloads of 80, 100 assigned to a therapist, and the therapist would only do the therapy piece of it. So we're going from a old school concept to really branching out and saying there's got to be a better way of doing this and leveraging everybody that's on your workforce to the fullest amount. Next slide. Really, when I was in the Boy Scouts, I learned to shoot a bow and arrow, and I got a merit badge in it. But the goal was to hit the center of the target, right? So the center of the target here is the client. The client is what we're focused on. The client is where we want to have our outcomes. The client is where we want to put all the services in, and we want to get down to that very nucleus of that consumer. And we're doing that with what Josh talked about, the ITMs, the care coordinators, the CPRSS, the family support specialists. They're right next to that client. And these are not going away from the client as much as they're all moving toward the center of the client. We have the RN, the occupational therapist. Of course, we have the providers. We are fortunate enough to have a board-certified child and adolescent psychiatrist at Grand that we're very fortunate to have, and team support specialists, clinical support team, all that work is being done at the front desk. They're all part of a team. They're not separated from anything. Everything is tied together and focused on the client. Josh, you got any comments about that?
I do. I just want to emphasize that last circle that you see out there, farthest from the client. So one of the most innovative things that we've wrapped into this team-based approach is going to be the idea of the support services that used to be centralized either at the front desk or maybe in a room behind the front desk, where we had people that were running reports, helping with billing and things of that nature. So by incorporating them into the teams, really they serve 10 core teams. So for every 10 core teams, we have a dedicated team support specialist that is on the back end ensuring that no one is falling through the cracks, and then helping us look at trends, helping us look at areas of concern amongst these teams, and making sure that everything is up to date in the charts, make sure that everyone has access to the services they need, they're scheduled, they're ready to be seen. So for us, it may sound mundane. For us, it was a very, very big decision to tie even to the level of support services to those teams and assign them to, have visibility on direct client outcomes. Next slide, please. Integrated team managers are going to be something that no one's ever heard of before. You know why? We made it up. So what we knew is we were in a situation where we needed to find a way to have more visibility on the people we were serving, and we needed to have that orchestrated. So we needed to create this hybrid clinical managerial position. And what this is, these are licensed therapists now that come to us, and half of their job is to provide direct therapy services. The other half of their job is to manage 2 people that are working with them. So that's going to be managing a care coordinator and managing someone with lived experience. So in this case, a family support provider, with the overall goal of orchestrating that care in a manner that gives the clients the personalized attention that they need based on the number of hours that they have available. So it's a very high level care coordination taking place from the expert, with the overall goal of getting positive health outcomes for the 40 people that are assigned to their caseload. Larry, do you want to go ahead and say a little bit more about that?
They're almost like a conductor. They're orchestrating a band or a concert, and their job is to a team-based care through direct supervision of 2 staff members. They're a conductor of this team, and they're making it work. It's amazing. They feel responsible. They feel adequate. They feel all the things that a person needs to feel in order to continue employment with you. This is bringing into our therapists. They're more than just a therapist. They get paid a lot more than a therapist, by the way, the old therapists. This is how we were able to bring our wages up and be able to pay to recruit and retain a high quality level of staff all the way through our system, not just with the therapist, but all the way through. Next slide, please. The family support specialists, we are really training family support specialists in some ways. Every time that we have a family that we're successful with, many times those parents recognize that, hey, this is a field that I would like to go into. And some of them are very good at this, by the way, because one of the things you have to have is a lived experience to be a family support specialist. And some of the services that we've provided in the past have really got those people interested in becoming a family support specialist. They're able to bring a personal, been there, done that experience to the helping of the relationships. They provide support and enhancement to family members, assess family developing and maintain, and all this stuff that they're doing, and you can read as well as me, but I won't read this out, but it is to do with, and then to cheer on all the stuff they're doing. They're constantly speaking and meeting with their the team, the LMHP that's in charge of the 40 clients that they're in charge of. And so they're constantly giving feedback and getting feedback from those therapists and from the care coordinator and other people on the team of what's going on, and making sure that we're on target of hitting our outcome that was set in the outcome-based treatment plan that we have. We have over 50 family support specialists working with families we serve right now. That's going to increase. The only way that you can increase access is to have staff to provide the services, by the way. You can give more access, but unless you have the staff there that's going to treat those people, you're really failing on both ends. So I'm really excited about the family support provider to enhance the LMHP impact and how this is actually happening, and it is working. Josh?
Yeah, I don't have anything to add to that slide, so we'll just go ahead and move to the next one, please. This is an exciting slide, and so we have fully engaged in the concept of outcome-based treatment since we've been a CCBHC. So our philosophies have changed, and we've applied that to everything that we do, especially when it comes to the clinical and operational decisions at our agency. Well, we don't just stop there. So we have an issue. We have a problem. COVID showed us turnover like we'd never seen before, and we weren't getting the applicants that we needed, and we had to solve it. The outcome we were looking for was more applicants and less turnover. That's what we had to have. We had to have the ability to have the adequate workforce to serve the people that we were charged with serving. So we came up with a plan, and this is the plan that we came up with. We came up with compensation that was sufficient to be able to recruit people. And let me tell you something. This sounds like it's a good idea. It is a good idea. It wasn't popular. When you're the first agency to take a step and everyone's paying the exact same rates across a region, and you make that decision that we are going to ask for more because we have to have more and able to get the outcomes we're looking for, and we're going to pay more, it's good until it impacts other people. Because guess what happened? People came to work for us from other places, and it made those places then increase their salaries, which then it made us increase our salaries, and it made them increase their salaries. And so what we have is this phenomenon now where you could look at a heat map of the United States and what the salaries were, and really you had some pockets up north, but really it's East Coast, West Coast, good salaries. And then now we may not be red yet, but we're for sure getting hot pink when it comes to the heat map and Oklahoma's ability to pay a living wage for people to want to work in this field. That wasn't enough though. The pay wasn't enough, and we were determining that pay may keep people around for a little bit longer, but there had to be something else. So we started looking at innovative ways that we were going to enhance people's time while they were there. People to be able to have enough wellness to be able to be productive while they were at work. We determined that, man, people on Fridays, they were there, but they weren't really there. Okay, they weren't providing the level of service that we would like. We decided we were going to give them every other Friday off, and in the form of a wellness day, so they could do the stuff they need to do. They could go to dental appointments, they could go to health appointments, they could go to the zoo with their kids, they could do the things they needed to do. So really, what we did was we decreased their productive time by about 10%. Our prediction was that we were going to get an 11% increase in productivity the time they were there, right? That's all we had to have was over the other times they were there, we had to have a 11% increase in productivity. We see it. So we saw exactly what we were hoping to see, with a 40% increase in applications and a 7% drop in turnover. So we also have a pretty robust internship program. We've been winning some awards with it, and we're growing it all the time. We're going to expand it to different levels of care, including medical mid-level providers and physicians in the coming months. So Larry, do you have anything to add to this slide?
Yeah, just real quick. Recruitment and retention. Recruitment is one thing, retention is something else. To train somebody, to find the right person, to get them in, to be able to pay them a decent salary, and make sure that you have a good cultural work environment, and that every other Friday off was a real winner for us, by the way. Next slide, please. Leverage technology. This is one of the most important things that we do, because we don't have enough staff to serve 12,000 clients right now that we have out there. If we have 12,000 open charts in rural America, where you may have to drive 30 minutes to 45 minutes to get to a client's home. You knock on the door and they're not there. So what we did is we created an app, put it on an iPad. We furnished the iPad along with a data plan. We do a lot of our services through technology. I mean, it's no longer do we have the no-show rate that we had because somebody's car wouldn't start, or they left their home late, and they're late, everybody's late. So the no-show rate plummeted. The number of clients participating increased, and the client status and the staff satisfaction went up, and the client satisfaction went up. Technology is your friend. If there's if your state is not reimbursing for video conferencing right now and using video for care management, case management, RSS, school services, all kinds of stuff. We have 8,429 iPads right now, probably more like 9,000 iPads, because we give them out every day, and we're treating new clients every day, and clients are needing them. And so when you look at that, somebody says, how can you afford to give an iPad and pay for the data plan and all that stuff? How can you afford not to, is my question. The return on investment here was tremendous. Something you might want to look at and see if it's a way to increase the number. You may not get more staff, but at least your staff will be able to see clients more often, and they won't have that no-show rate and other things. That's about a 20 to 30% increase in staffing simply by having the iPads out there. Josh, you got anything?
I do. I just wanted to point out that this represents opportunities for not only general service provision, but also it gives opportunities for crisis intervention at all levels. So when a family has access to an iPad, they have access to every one of their team members that we mentioned for general service provision. So all those barriers, sickness, money, transportation, just not wanting to leave the house. Sheamekah touched on it. We have families that need to be seen 10 times a month. It's that simple. It's hard for them to be able to get to us 10 times a month. It's hard for us to get to them 10 times a month. This makes that barrier overcomable, right? The other thing is, a question that I would have if I was listening to this is, what's the utilization like? So out of those 8,429 iPads, we have 10,000 plus calls coming through to our staff every month. So an average of over at least one service per iPad that's out there. It's likely that it's people that are utilizing these when they get comfortable with them multiple times, but every one of those represents a possible crisis diversion or a connection to a much needed appointment that may not have been able to take place had that iPad not been in place. So I think that this concludes our official presentation, and that we are prepared to answer questions.
And
yeah, we're 1 minute over.
You guys are great. And Sheamekah, some of these questions are for you too, just so you know. Okay, so I know, and now everyone knows, Oklahoma is known for iPads, right? Everybody knows that this has been a huge part of the expansion of work in Oklahoma. And so the question that came in was, everybody loves the iPad program. People are thinking that their legislators or governors, their elected officials might have concerns. They understand that, Sheamekah, you guys also give iPads to your police officers, right? That, giving to a professional in some states seems fine. Giving to a client, they're wanting to know how you got buy-in from the legislature and the governor's office and leadership, and just what was that path like?
Sheamekah, I want to talk just real quick and let them know that the iPad is in a single app mode and it can't be used for anything else. That is part of the buy-in. You can't have an app out there that or an iPad out there that people can go on the internet and do whatever they want to do with it. It has to be in a single app mode and a specific. I'm sorry, Sheamekah, I didn't mean to interrupt.
No. You're fine. So I'm going to talk from our state perspective. So as an example, let me give you one example. We feel like as a state, any opportunity we have to intervene in a crisis situation for an individual who has mental health issues with our law enforcement officer, the best possible outcome is going to happen. Okay. And so training our law enforcement officers through CIT, but then also providing each off-duty officer with an iPad, again, reduces the risk. Our outcomes with that population are better. We have an opportunity to transition juveniles with mental health issues into services and not down that trail of the juvenile system. And so for our state supported it. Larry, you may have to help me with the funding that we actually was able to use through our state in order to do this. Like, my brain is freezing right now. But in addition to that, I'm going to go back from the provider level. Like Larry mentioned, these iPads are designed to have one-way communication with our providers. But then also these iPads, we have the ability to find them if they're lost. Sometimes they're lost. They have GPS systems in it where we can actually locate them in order to retrieve them. Do we penalize people? No, the idea is not to penalize. But again, for individuals to have a device that they can't do anything else with, again, they are more likely to utilize it for the intent and the purpose behind it. And so again, the return on investments, as Josh mentioned, the fact that we have people in higher levels of need that may need to talk to someone each and every day. Unfortunately, they're not going to be able to drive to the office every day. Yeah. We're not going to be able to build those people in on a and so again, iPads make it much, much more easier.
You know, the iPad program started at Grand Mental Health back in 2015, 2016. Yes. And part of the reason that it was easy to sell for the legislators is because we had it in every police car in our 12 counties, and we saw a reduction in inpatient drop by like 93% reduction in people going to inpatient, because we were able to treat and meet the client at the police officer, plus the amount of people that were being arrested because they assaulted a police officer, because now all the police officer has to do is say, would you like to talk to a therapist if they come up on with somebody with mental health issues? So all of these things together, I think, is what tells the story. So when it comes to funding, all of these things, just several millions of dollars was saved by simply reducing inpatient stay.
Yeah. Larry, say that data point again. That's an impressive data point. What percent decrease did you just say?
According to the National Research Institute, which came up and did a study for us, it's a 93% reduction in people going to inpatient. Unbelievable. Yes. How you stop people from going to inpatient, you stop them going to the emergency room. How you stop them going to the emergency room is you treat them right there on the street with the police officer, instead of the police officer take them to the emergency room. So it was just these things that just kind of snowballed on top of each other. And so the state of Oklahoma, with their wisdom and knowledge and ability, said, hey, man, we've got something here that looks like it's going to work. So they gave us 100% of their support, and we've moved forward. And now we have 9,000 iPads in clients' homes and another 1,600 in police cars and libraries and schools and churches. And I mean, we put our iPad out there everywhere a person that could be going into having a mental health crisis is.
Right.
So we call it unbridled access, right? It's not open access. It's anywhere someone could have the thought, maybe I could use some help right now. There's a button to push. That's the goal. Let me tell you what the other data point that coincides with this is that you would think that our crisis numbers would have gone up at the same time, because we're treating them maybe at a lower level of care, but maybe a crisis level of care. So by giving iPads to individuals that were accessing services, our crisis numbers dropped at the exact same trajectory as those inpatient numbers. So the crisis numbers didn't go up while inpatient went down. Everything dropped simultaneously. So those higher levels of care greatly decreased.
That's so helpful to hear. People are really interested, asking for links and all kinds of things. So we'll follow up with everybody and make sure you get this information. One question that came up though was, how do iPads work in rural areas? Do you have access issues, internet?
Yeah. First of all, we're with First Responder, which is a product that the federal government made sure that AT&T, I believe, is, and we are the same as a police officer, a fire department, or anyone else on our iPads, and so it will find a tower even in rural America. I mean, it just keeps bouncing until it finds it. And plus, the iPad was designed, and the software is designed in such a way it uses a very small stream of data to run the video and the voice. So it's specialized just for rural America. So it works well in urban for sure.
Great. That's great to hear. There's a question in the chat regarding and we see this all across the country, right? Right now we have ED boarding, we have emergency placements that are staying inpatient for well over the time that they clinically need that. And so I guess this goes first to Sheamekah and then to you guys, Larry and Josh, but like in the state of Oklahoma, given how you've built things out right now, what's your experience in that trajectory that we're seeing, and what are you doing about it?
So I'm trying to figure out how to say this. So, and referencing specifically Grand Lake, in the area that they serve, they are the crisis provider in addition to the CCBAC. And so I received a lot of phone calls early on with their diversionary practices, because if in fact you interface with Grand Lake Mental Health mobile response and stabilization services in the state of Oklahoma, your child has an 86% likelihood of not going into an inpatient. And at some point, it went up to 90. In addition to that, the fact that parents have the ability, when they have these kids that are really high need, have the ability to receive these iPads. And in some cases, these iPads have prevented kids from going into care. And so I say that respectfully, it has the ability to really do an amazing diversionary process for kids that are in need of higher levels of care. Do we still have kids in crisis that actually go inpatient? Yes, we do, because they need to be there at that particular time. In addition to that, our ability to connect with inpatient providers in a way where the coordination, utilizing the types of teams that he spoke about to coordinate services from the time that they're inpatient to the time that they come out, is really significant and important to make those connections. So that's it. It has the ability to have a major impact.
So Larry and Josh, you lived through that. What would you like to add to that?
But we're in the process of opening up a brief therapeutic home, and we're more looking at family crisis centers. The same
Right.
concept that we have with the adults, right? If somebody's in crisis, they just walk into our crisis center, open 24/7, 7 days a week. When they leave
Right.
with an iPad, and they leave with wraparound services, so they don't recreate that crisis again. And for those children that are at high risk of being placed outside the home, we built a house, a 4-bedroom home, 2-bath, and we're going to bring the family in, and they're going to spend a week with us, and we're going to do very intense services while they're in the home, and get that client, and hopefully keep that child from having to go. And those are the children that are in need of intimate placement, outside of placement inside the home. And so we're trying some new stuff. There has to be something between just the outpatient services and inpatient. It's got to be something built in between.
Yeah.
Department of Mental Health is very supportive of us building that type of stuff. Go ahead.
That's great.
So really what Larry's, two things Larry's talking about. One, we have this urgent care model for kids, 24/7 urgent care services, psychiatric urgent care services for kids in the state of Oklahoma that we're building out. And so, like Larry said, kids will be able to have access to that type instead of utilizing an emergency room. We want our kids to come to us.
Yeah.
The second part is really amazing. And again, these services that are going to be provided are going to be services that are going to be built up on a reimbursement. And in most cases, it'll be a Medicaid reimbursement. But the idea that they have these homes that they're going to build across their catchment areas where families can have real-time family-style respite, not just real-time family-style respite, but the opportunity for kids that are in custody to re-engage with their borrowed parents in a way that they can be successful after that. The opportunities where kids have continuous cycles of inpatient to go to a respite type environment in order to work through a clinical process to talk about strategies for stabilization, communication, and those things that are significantly important. To me, I get excited when I hear about what they're doing because it is just, again, innovative, creative, and it meets the needs of the kids and families we serve. And all of it, Josh, these things are built up on a reimbursable source.
So on that note, I apologize, you guys, because I know I could let you go for 30 more minutes, but we are over. So we have to wrap this up. We have given people your contact information. I am confident they will be reaching out. These slides will be available. This whole presentation will be available. Please share it out amongst your colleagues. Thank you so much, Oklahoma, for coming and talking to us about all the great work that you're doing. It was great to hear your story. Your impact for kids and families is just amazing, and we thank you all for the work you do. So I'm going to wrap us up. Take care, guys. Thank you.
Thanks, everybody, for joining us.
Thank you.
Y'all have a great evening.
Thank you for joining this month's Child and Family Focused Certified Community Behavioral Health Clinics Learning Community, hosted by the CCBHC Expansion Grantee National Training and Technical Assistance Center. Please take a few moments to complete the evaluation for this workshop using the following link being posted in the chat. We will be providing a certificate of attendance for completion of each workshop being offered throughout the entire series. So make sure you're registered with the same name logged into each webinar so that we can confirm your attendance and the total time you were part of this workshop. Please allow up to 10 business days for your certificate of attendance to become available and ideas at the Institute. Any presentations, resources, and webinar recordings will be made available to you within Ideas at the Institute. Once you are registered for the learning community, you will have access to all the upcoming and previously recorded webinars. With our goal to support increased access to and improve quality of CCBHCs in meeting the needs of youth and families, we hope you join us again.